Good afternoon. I'm Lynn Videcka, Dean of the University of Michigan School of Social Work, and it's my distinct honor to welcome you to the 2017 Leon and Josephine Winkelman Memorial Lecture. This is my first Winkelman lecture. I know for many of you this is an annual event and annual lecture that you attend, and I'm so pleased that we have a very nice-sized crowd today. It's going to be an exciting and engaging presentation and conversation. We want a lot of input, questions, and conversation from the audience, and from what my colleagues tell me, we can count on the Winkelman lecture audience for just that, so that will happen a little later. Let me start by telling you a little bit about the Leon and Josephine Winkelman Memorial Lecture. It was established in 1978 here at the University of Michigan School of Social Work with an endowed gift from Stanley J. Winkelman and his brothers. And this gift was a memorial and tribute to their parents. Stanley's father, Leon Winkelman, co-founded Winkelman Stores in 1928. Anyone ever hear of or go to Winkelman Stores? Sure enough. So Leon co-founded Winkelman Stores with his brother Isidore. Stanley's mother was a 1919 graduate from the University of Michigan social work program. We weren't quite a school at the time. That came a couple years later. And she worked at Hull House, which is a famous settlement house. Anyone hear of Hull House? Yeah, quite a few. Settlement house in my hometown, Chicago. And it's famous, of course, because that's where Jane Addams began her work on community change and community activism to support immigrant populations. So the Winkelman Lecture provides a forum for presenting new and emerging knowledge from social sciences and from the helping professions, all focused on the field of gerontology. We also, in the lecture, make a special point to ask a panelist and a keynote speaker who can relate to social policy, the organization and management of social welfare services, and the delivery of social work services to older people. Stanley J. Winkelman was a leader in civic affairs in Detroit. After the 1967 riots sent other retailers to the suburbs, I'm very proud to say that Stanley Winkelman kept his family's department stores in the city, hoping that their presence would contribute to and sustain an environment suitable for doing business. Mr. Winkelman was deeply involved in social justice issues throughout the city. In 1963, as part of the Detroit Commission on Community Relations, he called upon the Detroit Board of Education to hire more black teachers to further desegregate Detroit's teaching force. In 1967, he led a new Detroit subcommittee on community services and called for an investigation of Detroit's police department. Stanley passed away in 1999, but his legacy lives on in the Detroit community and here at the University of Michigan. We're very thankful to the Winkelman family. Unfortunately, none of the family members could be here today, but I spoke to Judge Winkelman, who lives in California, just in the last week. So he sends his regrets he can't join us today, and for this wonderful annual event that informs our profession and provides us with an opportunity to honor our alumna, Josephine Winkelman, and her husband, Leon. So for today's lecture, we're fortunate to have one of the true and long-term leaders in the field of gerontology, Dr. Robin Stone, who will deliver our keynote presentation. The presentation is entitled, "The Future of the Aging Social Workforce, Moving from Accident to Valued Profession." Now that's a pretty provocative title, and I'm sure we'll have lots of great conversation. I had a preview to the ideas last night at a pre-lecture dinner, and they're very exciting. And I can tell you we don't have a shy panel, and we don't have a shy keynote speaker today, so it should be a lot of fun. Following Dr. Stone's presentation, we brought together a terrific panel of interdisciplinary experts to provide their unique perspectives. School of Social Work Assistant Professor Jamie Mitchell will be serving as moderator for the panel discussion and conversation, and she will later introduce the panelists. I won't introduce them right now. But it is my pleasure to introduce our keynote speaker, Dr. Robin Stone. Robin Stone works at a leading aging policy advocacy organization called Leading Age. She is executive director of the Center for Applied Research, and she is also at Leading Age the senior vice president for research. The organization is located in Washington, D.C., and Leading Age describes itself as a trusted voice for aging in the United States. I looked up a little bit about the organization. It has over 6,000 members, and these include nonprofit organizations. 38 states have affiliated memberships, businesses, consumer groups, foundations, and research partners. So it's a very diverse and a very large membership. Dr. Stone is responsible for developing and overseeing an applied policy research agenda at Leading Age. And that agenda focuses on developing and translating evidence-based approaches to advancing quality in aging health services. The agenda also includes developing a quality workforce and enhancing residential options linked with health services for older adults. The goal of the Center for Applied Research is to create a bridge that is so much needed between research, policy, and practice communities, all for the goal of better services and better programs for people who are aging. Dr. Stone has held senior research and policy positions both in the U.S. government and in the private sector. She was a political appointee in the Clinton administration, serving the U.S. Department of Health and Human Services as Deputy Assistant Secretary for Disability, Aging, and Long-Term Care Policy, and as the Assistant Secretary for Aging. Robin Stone is a distinguished speaker and has published widely in the areas of long-term care policy, quality and chronic care for disabled people, aging services, workforce development, and low-income senior housing, as well as family caregiving. She serves on numerous provider and nonprofit boards that focus on quality services for older people. She is a fellow. She has many distinctions, including being named a fellow of the Gerontological Society of America and also a fellow at the National Academy of Social Insurance. She was elected to the National Academy of Medicine in 2014. Please join me in welcoming Dr. Robin Stone.
Thank you so much, and it's a delight to be here. And I just love the fact that this is a Winkelman Memorial Lecture. I wish I had been able to meet them. They sound like my people. My kind of people, and sure as heck we need a lot of them right now. I wish that Stanley were around because we need community leaders to help us. And I would also like to say that I do know that there are some Leading Age members in the audience. I always love to go places where we have some of our membership. The beautiful thing about working at Leading Age, and I was just talking with Claire about the fact that I've been there for almost 17 years, which is just totally unbelievable. I never stayed in a job that long in my life. But working at Leading Age has really given me exposure to some of the most fabulous on-the-ground providers who really care about older adults and community. And that is what really this is all about. And so that job over the past 17 years has given me amazing opportunities to really learn what's going on inside the black box of caring for our elders and thinking about all kinds of options for the future, just at the time when we are about to really start to see the bulge of the baby boomers. Those of us who are in aging services, we're sort of the pioneers. We're really in the cutting edge. I started in this work when I was 26. I'm 66, so that's 40 years of working in aging services, starting with running a nutrition program in Baltimore in the early 70s. And I can tell you that we aren't as far along as I think we need to be. Unfortunately, those of us who have been sort of carrying the mantra of aging services for a long time, I think we would like to be a lot further along than we are. But I think we've got a couple of things on our side. One is the demographics. We are going to move from about 14% elderly to anywhere between 20, 25, and even 30% elderly, depending on the community over the next 20 to 25 years. That's huge. And it also provides us with tremendous opportunities for thinking not only about the productivity and the contributions of older adults themselves, but what I've been very passionate about and what I think has been sort of the sleeper issue in aging services for a very long time. And that is really, how do we move from accidental to valued profession? I'm going to talk a little bit more about this, but how many of you right now are working in some type of aging services? How many of you are receiving some type of aging services? How many of you have parents or siblings who are receiving some type of aging services? I mean, one of the things that is pretty ubiquitous in the United States, but not only in the U.S., but actually globally, is this aging phenomenon. And almost everybody gets touched by these issues and the need for addressing these issues, both on the social service side, on the healthcare side, and sort of in an integrated fashion. What's interesting, however, is it has been very, very hard to get aging services professions on the radar screen in the way that they need to be for meeting the needs of the next 25 years. Why I call this accidental is that many folks have gotten into aging services by default. Not all of us, some of us. I mean, I chose to go into aging directly out of college. I had a very close relationship with my grandparents. My mother was a single parent, and my grandparents really raised me. So I had incredible relationships with them, and I always knew I wanted to work in aging. For many folks, they fall into these jobs. They either burned out in another environment, or they happen to be working in social services, and somehow they end up in aging services. There's a lot of pathways. But what we need for the future is for us to make this move from a normative accidental profession to actually a set of professions that everybody wants to go into. These are the jobs of the future. We need to put a value sign attached to it, and that's really what my talk is about today. I want to start by talking about what the sector is. And I think it's a really interesting issue because we are not healthcare and we are not social services. We are a total mix. For the most part today, I'm going to be talking about the sector that is outside of the hospital and primary care. That's not to say we don't have a lot to do with them. But as I always say to the folks that I work with, you don't live in a hospital. You don't live in a primary care office. We spend, and we should spend, very little time in those settings. I'm talking about the settings where most people live their lives. Starting with post-acute skilled nursing and home health care, residential care settings that include nursing homes, assisted living, memory care, personal care homes, whatever it's called in your particular state. I'm not exactly sure what some of these different residential options are called in Michigan, but it's a level of care that is above independent living where there is some level of need and services provided. And then, of course, we have independent living. We have both market rate and we have publicly subsidized, either by the federal government, the state, or a combination of those things. And then the whole expansion of home and community-based services, home care, personal care, assistance with what we call instrumental activities of daily living, supportive services like transportation and meals. If I were to identify one area that is consistent across the country, it is the need for transportation. And who knows what the answer is going to be. Is it an Uber of the future? Is it driverless cars? Is it a really robust public transportation system? Is it a combination, a hybrid of these things? And this is probably a really big issue in the town that was known as the auto industry arena, right? Because this area was built on cars, and yet that has become in many ways the nemesis of a large proportion of our elderly population when they can no longer drive. And it's particularly problematic in suburban and in rural communities. And then, of course, this whole area that is not new, by the way. Those of us who are in the social work world and social services know care coordination and service coordination. It's been around for a long, long time, probably since Hull House. The medical establishment has now found it, and they're hiring. And they're creating their own new care coordinators and nurse navigators and whatever. But it is the world of aging services, because forever folks who are working in this sector have known that in order to make it work, we have to coordinate and bring together all of the types of services that are required to allow people to live as independently with choice for as long as possible. And that is really what this sector is about. Now, the thing that I think has been missing is that we talk a lot these days about how to finance and how to transform our system, but somehow it seems like that's going to happen magically. And the latest iteration of it is that if we just had some kind of electronic health record that went across settings, or if we just had some type of technology to solve our problems, everything would be fine. And I get emails every single day from tech companies that are trying to sell us something at leading age. And I am not a Luddite. I love technology, just like the rest of the world. I have my own phone, my smartphone. I use it all the time. I'm connected. But the truth of the matter is that, at least for the foreseeable future, nothing is going to replace human capital. And what's missing in our discussions, in our policy discussions, and unfortunately in our practice discussions, is the development, the sustaining, and the evolution of a quality, competent aging services workforce. And I think if I leave you with one message, that is it. It's the people, stupid. We are nowhere. We will not produce quality. We will not get to the outcomes that we want without investing in staff across every single profession. And that is really my goal today, is to sort of highlight that and then to figure out with the panel how we might think about moving this agenda forward. One of the things that I think is really interesting about aging services, and what appealed to me in working in gerontology in general, is that it was extremely multidisciplinary. And I love the fact that you can't solve the problem with just one discipline. It also makes it incredibly challenging. But I do think that that is the novelty and the potential for innovation in our sector, is this medical, social, environmental intersection. That's what makes this so cool, that our professions are not just one thing. You know, we're not narrow in one little box. We have to understand the whole set of how social, medical, and our environment works together to either support or get in the way of having healthy, age-friendly living environments. We have a range of job categories. When we talk about clinicians, unlike the acute care sector or the primary care sector in healthcare, the nurses and social workers are the leads, which I think is awesome. And I happen to be at a social work school, so I want to put that forward, that this is where the leadership comes from in our organizations. We need to take advantage of that and move that forward in terms of really assigning more and more value to these jobs. Physicians, although are important, are relatively minor in our sector, and in many cases need to be brought along because they don't necessarily understand the holistic and the intersections between these various parts of our world. And so, this is really critical for us, is to take the lead in terms of trying to sort of frame what this workforce needs to look like. Therapists are incredibly essential in terms of function, whether it's physical therapy, speech therapy, and a growing evolution of the occupational therapist, which it's interesting, more and more people are paying attention to the fact that we have to live in our environments, which means changing and modifying the physical environment and having people who can help us understand how to wend our way through it. Like, there's an actual right way to use a cane, I mean, you don't just give somebody a cane and say, okay, go out there, fend for yourself. And so we're starting to see the important need for these kinds of professions that work together. Pharmacy, obviously, is very critical. We are in a world of polypharmacology, whether we like it or not. And we need to understand what's good, what's bad, and how we use pharmacy in the appropriate and adequate way so that we don't really deal with some of the iatrogenic effects of having a lot of interactions that are really, really bad for people. Dietitians are also essential around nutrition, and then health educators. So within that range, you can see we already have a lot of occupations that need to be developed with a core of understanding the gerontological and geriatric base, that there's something special about working with older adults. We certainly know that when we think about kids, right? But the same investment has not been placed on working with older adults. And as we start seeing our population age, there's going to be more and more of a demand for that. The question is, can we meet that demand with quality and competence? Administrators and managers are also essential for this field. And what I worry about, quite honestly, is that we haven't invested in management, and we haven't invested in our administrators. Nobody wants to be an administrator of a nursing home anymore. They all want jobs as heads of health systems. And the truth of the matter is that the evolution of our sector is going to grow, and we're going to need more and more of these folks. What about all the movement into home care? That's not going to work without quality administrators who know what the heck they're doing and who understand how to manage people. And yet we have had very little investment. And if you look at business school curricula or you look at management school curricula, you'll find almost nothing. And a number of our schools that have tried to evolve aging services programs have struggled. So somehow we got to help to turn that on its head. And then, of course, I left this for last, but this is the last and the best, which is our frontline professionals. These are our certified nursing assistants, our home health and home care aides, our personal care attendants, our dietary aides, our medication aides, all the folks that do between 60 and 80% of all the hands-on care in our system. And what do we call most of these workers? Anybody got an idea? We call them low-wage workers. Now, what do you think that nomenclature does to that job? It not only doesn't help it, but it hurts it. And I would argue that we in the provider community and we in the policy community have actually made it worse by continuing to talk about this workforce as low-wage, unskilled, or maybe sometimes we call them semi-skilled. And, the Paraprofessional Healthcare Institute actually changed its name to PHI because they recognize that they're not paraprofessionals. These people are professional staff. And, I would challenge most of us to do the level of work that many of these individuals are doing today in our organizations. So that's got to be at least the foundation of the work that we do, which is there has to be a level playing field around how we talk about professionals in our sector. And to me, it's the beginning, because language means something. And when we label it, we can actually assign a monetary value to it. And if we label something low wage, we continue to expect low wage. And if we label it as a highly skilled professional person, we no longer will accept that, including the families who want to hire cheap labor. They're not hiring a babysitter. You know, I mean, I have nothing against babysitters. I had babies. I now have grandchildren. But this is not babysitting jobs. Or as I used to tell Senator Rockefeller when I worked in the Clinton administration, these aren't butlers and maids. And yet, truthfully, that's how a lot of folks still think about them. You know why policymakers aren't paying any attention? Because they still have that image. And if you look at the competencies of these folks, you will know very quickly that that is not what they're doing. The studies have shown that a frontline CNA will pick up a changing condition 5 days before your nurse. So they are pretty essential for our workforce to be successful. And then, of course, we can't forget the family and friends who do the lion's share of all the care in our society. And we could have a whole lecture, we could have a week on family caregivers. So what do the long-term trends look like? Well, we all know, or some of us may know, that we are going to see an emerging care gap over the next 25 years, just as we're starting to see the expansion of the baby boom generation. And a lot of this is demographic. So what is happening is that we're seeing a shrinking of the age group that is in the category that would be most likely working in our organizations. So the age group between 35 and 54 is going to be shrinking as part of the workforce, and it's a demographic phenomenon in most parts of the country. In some places, we're already there. Go into rural communities, you can't find somebody 35 to 54 to do any jobs, let alone, I mean, we have leading age members in Nebraska and Kansas that are closing because they cannot find staff. So that's the sort of the bellwether for what we're going to be seeing in the future. And one of the main reasons why we're not worse off than we already are is because of immigration. Immigration has helped to fuel our sector for the past 25 years, particularly in our front line, but it is also true for our nurses and for a number of our other professions. And quite honestly, we need to be paying attention what's going on in D.C., because it's going to affect not only our front line, but also some of the folks who are here on either temporary or permanent visas. And this is just the tip of the iceberg in terms of us understanding how immigration policy and those decisions that are being made are going to affect us in the short term and in the long term as well. So this is critical for us. The other thing is that we're probably going to be seeing a shortage of family caregivers. And that's because of a number of things, including the fact that we're seeing a growth in the childless childless population that would have been there to have children to care for them. So more and more baby boomers do not have kids at all. You know, if you do family caregiver research, you know it only takes one child. Because some people tell me, oh, you know, we used to have such big families, now we only have one. It only takes one. Because mostly you only have one that does most of the work. And it's true. I mean, I did a lot of work in family caregiving, and the empirical literature, the regression analysis will show you that it's one, and it's typically the adult daughter. But as we lose that, we are going to have to depend a lot more on fictive kin, other kinds of folks who step in. And we are expecting that we're going to see a lot more demand for our labor, just as we are seeing a shrinkage of the population that is most likely to be available, which means that we have to be smarter in terms of how we recruit, and we have to be smarter in terms of how we retain. And we also have to be creative in terms of recruitment in new areas, and I'm going to talk a little bit about that. But I just wanted to keep in your mind that with this emerging care gap, this movement around immigration policy is really critical for us. We're also going to see an increasing shift away from institutional to home and community-based settings. We're already seeing that. And I worry about that because I think that we have underestimated what it means to have a quality home care workforce. These are virtual jobs. It is really, really difficult to think about good management practices, good ways of creating workplace communities for folks who are out in individuals' homes. And we've basically just taken it for granted. Oh, we'll move everybody out of the hospital in 3 days, send them home, and we'll have a magical home care workforce that's going to solve the problem. And most of that work, by the way, is done by aides. Even in Medicare home health, you have skilled nursing, but you also have a lot of aid services that go on. So this is not just turning this over to the community and expecting that it's going to happen magically. We have to be very thoughtful and systematic about how we think about creating these environments. You know, in Silicon Valley right now, venture capitalists have just put millions of dollars into an Uber-style home care model called Honor. Basically, you just call up and they match you. Now, hopefully, and I've talked with Seth a number of times, the guy who was at Google who has started this, about making sure that there's a quality infrastructure behind that. Because it's one thing when you get an Uber driver who has not been vetted. It's another thing when you get a home care worker that hasn't been vetted and where there's no supervision and no in-service. So, you know, as technology moves us along, we have really serious challenges that can be turned into opportunities because there's something fabulous about the potential for that technology. But it's got to be done in a way that we are producing quality, competent people to serve in our communities. We're also going to see a much more ethnically and racially diverse older adult population than we have in the past. Right now, about 80 to 85% of all elderly in the U.S. are white. That's going to shift to about 2/3, which means 1/3 are going to be non-white over the next 20 years. Right now, we tend to have a lot more white elderly who are being cared for by much more culturally variant workers and staff. We're going to see more and more non-white elders with very complex changes in staff, and those just raise the specter of what are we doing around cultural competence and working with staff and working with our older adults to understand the dynamics of how we all work together. And that's not just about English as a second language, or, as I always say, having a potluck where you bring your favorite dish from your country, which in some of leading age member organizations, I have to tell you, that's what they think cultural competence is. They don't understand that people have very different views of aging, of death and dying. Try to get African American folks, for example, to sign an advance directive. It's not in their culture. Try to get people of certain Hispanic origins to have any kind of conversation without the family being there at all times. And we have to understand these things as we see growth in these populations, as well as understanding really the tremendous cultural diversity that we have in our staff that can be an opportunity but also can really get in the way, particularly when you have staff of some backgrounds who are managing and supervising staff in another set of backgrounds. And trust me, that's a lot of the undercurrent of what goes on in many of our organizations that are not healthy. It is about them not understanding and respecting their various cultures and knowing how to work with each other. We're also going to continue to see greater disparity between the haves and the have-nots, and I will tell you that probably the ugliest secret of all is that we have had the wealthiest cohort of elderly ever in the history of the United States. And it's about to go south. And it's going south for a number of reasons. 2008 didn't help us, didn't help the portfolio of many baby boomers. But if you look at the cohorts coming up who are aging over the next 25 years, many of them are going to be living on fixed incomes, and they have a high probability of living till at least 95. So longevity is great unless you can't afford it. And, you know, this is the dirty little secret that I tell all of our continuing care retirement communities. in leading age. And that's not the answer for the 21st century. We need to be figuring out new models that have new kinds of workforces to get out into the community for the vast majority of middle class and lower middle class folks who could never afford some of the environments that some of our leading age members offer today. We also are going to see the expansion of more and more consumer direction, more choice, more autonomy, more of older adults being in charge. Gone are the days of paternalistic aging services agencies that do everything for you, and older adults of the baby boom generation are not going to want that anyway. But that comes with a lot more questions around responsibility and liability in a very litigious society that we live in. And finally, I do think we need to figure out the impact of new technologies. But I would like to see the discussions turned on their head. Rather than we're always talking about what's the new technological fix, I would like us to talk about what technologies are going to help our staff do our work more efficiently. And that is a very different conversation than we have in most of our organizations today. And certainly policymakers are not paying attention to that when they think about how they use money to incentivize new types of models and new programs. So the importance of this sector, just to summarize, is the growth of the elderly population really means that these are the fastest growing occupations in many localities. These are the jobs of the future. It's not manufacturing, folks. And even if you brought jobs back, that's at best 7% of the entire sector, of the entire economic sectors. These jobs are huge, and if we can make them viable and valued, they can be a solution to a lot of our economic problems in many communities around the country, including parts of Michigan. New models of care are raising the specter of new types of jobs in this sector, and I think we haven't even seen the tip of the iceberg yet in terms of how we become creative around this. And then finally, I would say that, you know, there's so much emphasis on quality now in our sector, and yet we pay relatively little attention to the quality of our workforce. In the nursing home sector, we have 400 pages of new regs that came out. Most of them, and granted, I have real issues with a lot of it, but at least there's a lot more focus on person-centeredness in these regs. But a lot of it has to do with counting ratios of staff. And I will tell you that with very little evidence that it produces better quality, what does produce quality is quality of our workforce. And instead of counting what I call warm bodies, we ought to be looking at the quality of the people that we hire and that we retain. And that somehow is not, it's not even in the purview of many of our organizations, partly because we're struggling so much just to keep people. And as soon as you see the economy getting better, it actually gets worse because you have people leaving. They're leaving for a dollar more somewhere down the road, mostly not going to McDonald's, by the way. They're going to other parts of the healthcare sector. Most of the churning is not to flip burgers. It is actually to make more money in a hospital or a clinic. So the challenges to our workforce development, I've been looking at that, but I know I was told to move this mouse around because I went blank. Well, it's all right, I can see it. Our challenges are lack of quality supervisors. From a practice perspective, if I were going to tell everybody in this room who is in an aging services organization, the reason people leave jobs, whether they're a CNA or a home care aide or a nurse or a social worker, is they have horrible supervision. And we have very little investment in our sector in good management practices, coaching, nurturing, supporting our staff. We need better management acumen in our sector. And I would say that we need business schools and our professional schools and our management programs to be working together to develop this part of our sector, because there's a lot of opportunity for management in our sector if we were going to actually invest in it. What we do now is we grab the nurse that was a good clinician and we make her a manager of an entire set of CNAs or home care aides. And she couldn't manage her way out of God only knows what. Quite honestly, in many cases, I think making a social worker a manager of an entire floor or a group of aides going out into the community is a much better idea, because those are the folks that are actually trained to work with people. And yet we don't think about this. The trajectory has just been so narrow in our sector. I think it is an incredible opportunity for the social work profession to start thinking about management. Some of the best CEOs of the organizations that I work with over the past 17 years have been social workers. And so it's really important for us to think about this as part of the professional development. We have inadequate in-service. I don't know how many of you are in aging services, maybe working in a nursing home or assisted living. You put your staff in front of something called Silver Chair, and you put them in front of the same videos every year. And you know what? When we go to talk to these folks, they laugh at the training. They laugh at it. They're like, they keep showing us the same thing every year. We don't learn one thing. We don't have any opportunities for practicing anything in our organization. And this is what goes on. We have lack of career mobility. As I said, part of the struggle in our sector is we have a fairly flat hierarchy, so we don't have as much career opportunity as there may be in some other sectors. On the other hand, I don't think we've been creative enough in terms of thinking about career lattices and ways of creating new jobs. As I said, there's a lot more management opportunity in our organizations than we have taken advantage of, and so instead of doing that, people leave. And then we have inadequate compensation and benefits, and this is true across the board, whether you're talking about a home care aide or you're talking about a nursing home administrator. There's no parity between our sector and the healthcare sector, for example, which is our biggest competitor. And I'm going to talk about a couple of solutions to that, but I think we also as organizations need to be thinking about that as well. And then we're not really competitive technologically. So what are the policy solutions? I would argue that the next time that you have anybody going to your state legislature, or as we start talking about Medicaid block granting or per capita caps in the United States, which is a scary thought in and of itself, that we need to make everybody understand that these programs are what pays for our staff. Our sector is heavily dependent on Medicare and Medicaid, much more so than the rest of the healthcare sector and much more so than a lot of other economic sectors in our country. So those reimbursement rates drive what we pay our staff. And I don't think we've done a good enough job of tying these programs specifically to the human capital and the lack of investment. And every time we go to talk about reimbursement rates, we need to tie it specifically to the economic situation and the way in which we're going to create a healthy community with people who not only have enough money to feed their families, but who actually become productive and start to buy things in the community. Because the more money you have, the more they spend, and that's what we need. That's the economic driver in all of this. So we need to be clearly making the connection between Medicare and Medicaid reimbursement and our workforce. We have to begin to include real quality workforce indicators in looking at our outcomes. How many of you in the aging services world do continuous quality improvement in looking at your quality outcomes for the people that you serve? Are you doing the same thing for the quality of your workforce? Do you collect data on your workforce and continually look at the outcomes, turnover rates? Why are you having so much turnover? Why are you having problems in your organization? And how do you actually help to make a difference there and improve that? That's CQI in your workplace. And we really haven't paid attention enough to that or look at indicators that show us that we have a healthy workplace or not. How do we begin to think about getting a hold of some of the GME dollars that are used to develop doctors and some of these other professions? GME dollars come directly out of Medicare. We're serving the Medicare population. I've been told in Washington, D.C. that GME is the holy grail, and if we start trying to get in the way of academic health centers, they're going to scream bloody murder. And I would say let them scream, because these are the jobs that are being developed, and we need those GME dollars to help us develop it and to help us have the right curriculum in our professional schools, to help us have the right training programs, to help us have the right clinical placements, and to help us get more support for the folks who are going into our sector. We have to support investment in these jobs in worker shortage and disadvantaged communities. Maybe we need a national service corps that goes into more rural and suburban areas where we have had a hard time finding staff. And using immigration policy to better target, as opposed to these, looking at getting rid of immigrants, thinking about how we intentionally consider the use of immigrants in the future for all of our positions, where we're going to start to see shortages of actual human capital itself. And then I would also say we need to explore delegation opportunities more and more. Now, this is probably most problematic in nursing, because nursing has been very covetous of its licensure and its regulation. So God forbid should you delegate medication administration to a CNA, and yet we know in states that have delegated that med techs and med aides do very, very well with good supervision. I would argue that in licensed clinical social work, we ought to be doing the same thing. We could be developing whole cadres of frontline workers where we delegate, we become much more of the supervisors, and we therefore also have the ability to use our resources more efficiently and more effectively. I think delegation is just something that we're going to have to deal with, and I think from the professional world, these are turf problems, and we got to get over it, because the future needs to be thinking about everybody practicing to their highest level of ability. And I can say that because I'm not a licensed anything. So I've taken on every profession in some of my talks, and I understand all of the issues behind it. But from a policy perspective and a practice perspective, good delegation with really good supervision makes a lot of sense, and I think it would also help us to create more jobs. So what do we do in education? We need to develop faculty. One of the things that I hear a lot, now this may be more true in nursing, I'm not sure whether it's as true in social work, but a lot of the problems that we have in getting people trained more specifically in our sector is that schools cannot find faculty to teach this. So we need faculty as well as really good curricula that focuses on caring for the elderly. We need much better quality clinical and management placements. If you have a social worker or a nurse or a therapist that goes into a setting and they have a horrible experience, they are out of there. They will never work in aging services. If you have a good experience, an exciting experience, and you see that it's much more exciting to be working in these multitasking environments than it is to be narrowly pigeonholed in a particular area in other parts of the healthcare sector, for example, you will have sold folks on this forever. So this is incumbent on our organizations, our providers, to actually create the opportunity for folks to come in and have a really great experience. And then we have to reframe these programs for displaced and older workers. I actually believe there's going to be a lot more older workers who are going to have to remain in the labor force. And we need to figure out ways that this will work, whether it's ergonomic changes so that people don't injure themselves, whether it's job sharing, much more part-time work, much more flexibility in shifts. I think that is going to be one of our sources for a pipeline in the future, as well as displaced workers who are never going to be coming back into some of the manufacturing jobs that they think that they're going to be seeing. Workplace solutions include becoming an employer of choice. I think we need to have, and I heard that one nursing home has finally gotten the Malcolm Baldrige Award, which is basically a high-quality award for being an exemplary workplace. We ought to have this for all of our aging services organizations around the country. We need to be developing innovative career ladders and lattices. And we need to be supporting quality management and supervision. And that has to start with us as providers. There's nobody else that's going to do this for us. There's no magic bullet that's going to solve our recruitment and our retention problems. And then finally, I wanted to end this by talking specifically about the social worker roles in aging services, because I think that there are so many unbelievable possibilities. I was really heartened yesterday. I had a class of over 20 people, and some of them are here today. They came back. They're my groupies forever. And they were engaged. It was exciting. It has been hard to attract folks into social work, into gerontological social work. I don't understand why. I love working with older adults, and now I'm one of them myself. But we need to be developing opportunities for young people and mid-career people to get into social work, to think about roles as clinicians. Again, I think we've underestimated the potential for management jobs because this is human capital management. It's behavioral, it's communication skills, it's motivational interviewing, it's all the things that we learn as social workers. And I think that we have not tapped the potential for this profession to be in high and mid-level management jobs across the entire aging services spectrum. Administrators, and then obviously social workers were the original care managers. Don't let the system take over these jobs. You know, we need to be competitive as new models get developed. And then finally, we need educators. We need serious educators who understand the gerontological needs of the next 25 years. New models for social work. Of course, you know, we know the transitional care programs. A number of them are driven by social work. The Coleman model, the Rush model that comes out of Chicago, on and on and on. These are social work driven, with other clinicians being a part of the team, but social work is in the lead in these transitional care models because they realize when people come out of the hospital or they're going home from a sniff, they need more than just some clinical care. Their whole environment is essential for them in terms of staying and being healthy and being as active and as productive as possible for as long as possible. Community-based care coordination. I think we're going to see more and more of that, and the role of social work is critical. My own program, we are working with many, many publicly subsidized low-income housing properties around the country to develop a new enhanced service coordinator role in senior housing that is led by social workers who are going to get paid real money with caseloads of people that they manage and help to allow these folks to live in their apartments for the rest of their lives. And this will be social work driven. We are in the middle right now of a randomized controlled trial that is going to be testing a model of this in 40 housing properties around the country with social workers embedded in housing as the lead in these programs. And then finally, I just want to put in a plea for thinking about career ladders for our front line that don't just take them down the nursing track. I just met one yesterday who was a CNA who said, I don't really want to be a nurse, I don't really like blood. But she likes people. And she understands communication, and she understands behavioral issues. And social work is a really good track for her. And this should be a track for thousands and thousands of these frontline workers who I think would make incredible behavioral specialists and counselors and folks working with our older adults in all settings across the board. So I'm going to conclude with that. I want to thank you so much for this opportunity, and I'm inspired by the Winkelmans. I hope that, you know, we can continue in the 21st century to move this workforce along, but we've got to be the voices in academia, in the practice community, and in the policy community, because I don't think anybody else is going to speak for it except for the folks who really know it well. So Thank you so much. And I don't know who I turn this over to or how I do this, but we're going to have a panel, and then hopefully we're going to engage you guys in some discussion.
Hello, my name is Jamie Mitchell. I'm an assistant professor here in the School of Social Work. It's now my honor to introduce our panelists who will each have some time to give their thoughts on the lecture, and that will be followed by an open question and answer period where we will pass the microphone around for those of you who would like to give your comments or ask questions of the panelists. So first I'd like to introduce Dr. Sharia Robinson-Lane, who is a gerontologist with expertise in palliative care, long-term care, and nursing administration. She's focused her career on the care and support of older adults with cognitive and or functional disabilities. Dr. Robinson-Lane is interested in the ways that older adults adapt to changes in health, and particularly how adaptive coping strategies affect health outcomes. Her research is focused on reducing health disparities for minority older adults with cognitive impairments and their informal caregivers. Prior to coming to the University of Michigan School of Nursing, Dr. Robinson-Lane completed an NIH-funded advanced research rehabilitation training program in community living in participation with the University of Michigan Medical School. Jamie Lalonde, am I pronouncing your name correctly? Great. Jamie Lalonde is Director of the Memory Care and Life Enrichment at Glacier Hills, as well as the Administrator for the Memory Care Assisted Living within Eva's House. In this position, she directs not only the Life Enrichment team, but also the daily caregivers with an emphasis on mutually beneficial relationships where having fun at work is a key ingredient to a successful program. She attended Eastern Michigan University, where she obtained her bachelor's and master's degree in social work, as well as a graduate certificate in gerontology. She completed internships with Arbor Hospice, Glacier Hills, and the University of Michigan's Turner Senior Resource Center. During her career, she discovered a passion for working with older adults living with Alzheimer's and related dementias. Ms. Lalonde studied to become an associate trainer in the Best Friends approach to dementia care, as well as being a certified instructor for dementia-capable care through CPI. Educating caregivers on how to not only utilize their remaining abilities, she focuses on teaching families and caregivers how to make connections with the people that they care for. She also volunteers for the Alzheimer's Association as a support group facilitator and serves as a member of the Walk to End Alzheimer's Planning Committee. And finally, Claire Luz, am I pronouncing that? Luz, thank you. Claire Luz is assistant professor in the Department of Family Medicine, College of Human Medicine at Michigan State University. She's a gerontologist with 40 years of experience in the field of aging, first as a social worker and consultant in long-term care settings, then as a health services researcher. The majority of her research has been related to workforce development, particularly labor conditions and training of direct care workers. Other federal and state-funded projects have focused on falls, delirium at end of life, and the intersection of health, creativity, and the arts. She is most interested in community-based policy and practice-relevant research that leads to system changes that can feasibly be applied in real-life settings. Her current project, funded by the Michigan Health Endowment Fund, aims to build a sustainable infrastructure in Michigan for developing and supporting the personal care workforce. Dr. Luz served on the Governor's Long-Term Supports and Services Commission until it ended in 2015, and the National Quality Forum's Home and Community-Based Care Committee. She serves on the Michigan Society of Gerontology Board as past president and current treasurer. So I'll now turn it over to our panelists to give their thoughts, followed by a Q&A.
I wasn't sure if we were going up there or not. It's closer. It doesn't get much closer. I think I'll just take it off and hold it. How's this? Is that better? Okay. Well, first I want to say thank you to the Planning Committee for including me in this lecture series. It's an honor to be here. It's an honor to be with my new colleagues and, of course, with Dr. Stone, who's sort of an icon in my field, which is workforce development, particularly the direct care workforce. And like Robin, I've been in this field for 40 years. I didn't actually start out as a social worker. I started out as a direct care worker. And then went on to social work and worked for 20 years in the field as a social worker, all in long-term care settings, before going back to school to conduct research and teach. So Dr. Stone gave such a great overview, it's hard to know what to add to it. It was very thorough. I love your title because it is a valued profession. We need to, all of this healthcare professionals that she mentioned, we need to put more value on. So, as mentioned, the majority of my own research has focused on the direct care workforce. Starting with my dissertation, 20 years ago, I interviewed a whole bunch of independently employed personal care workers who go out and do this work on their own. And they negotiate, they find their own clients, they negotiate their own labor conditions, and I wanted to learn about their experiences. And what was rewarding about it, what was difficult. And what's interesting to me is 5 years later, some colleagues and I from Michigan State University conducted one of the first statewide surveys in the country of direct care workers. And that included nursing home workers and home care workers. And the findings were the same as what I found in my dissertation. So again, how and why did they get into this kind of work? Why do they stay in this kind of work? And if they're thinking of leaving, why do they leave? And this was funded by the state because they were beginning to realize what a critical issue turnover is. It totally disrupts continuity of care, right? And it's very expensive. And the turnover rate in this workforce is so high, and it has to be stabilized. That's one of the solutions. We have to stabilize this workforce. So in both studies, we found the same thing. Most workers do this work because they feel it's a calling. It's, as you said, they don't want to flip burgers at McDonald's. They want to help people. They want to work in the helping field. They want to be in health care. They don't want to necessarily be a nurse because, as they say, I don't want to pass pills and do paperwork all day long. So, moreover, they believe they have some skills in this area. They have an aptitude for this kind of work. Not everybody can do this kind of work. I'm sure you would agree. It was hard for me to do the work 40 years ago. It's hard for me to do the work today. I actually live with my 92-year-old father and moved in because he's failing, becoming more and more frail, needs more and more care. So it's hard work. And I'm just going to give you a quick quote from one of the interviews from a direct care worker. You have to be a certain kind of person to do this because it can be stressful. You have to like to do it, and you have to be fitted for it. Some people say, gee, I couldn't handle it if somebody was rude to me, or violent, or I had to clean up the bed mess or the vomit. It comes automatically to me like a fireman or a policeman. And by golly, it's like, what would we do without the policeman and the fireman? They leave the work for a lot of reasons that actually Dr. Stone mentioned. The pay is embarrassingly low, right? We should be embarrassed by the rate of pay we give these people. They leave the work because in nursing homes because of high caseloads. And I remember one certified nursing assistant saying, I quit nursing homes. I came out of nursing homes because I would leave every single day with tears and a heartache because I couldn't do the kind of work I really wanted to do. They leave home care for other reasons. They might not have a big enough caseload, or they have to travel 50 miles to get to a client and they don't get paid for mileage. Or, well, and one of the biggest things you actually mentioned was lack of respect and poor management. So lack of respect from their managers, the middle managers, but also lack of respect from society. So what's striking to me is 15 years later, here we are in this room. Nothing's changed. The problem's the same. The turnover rate is just as high. Employers can't find these workers. And when they find them, they say they can't pay them enough. They don't have enough money to train them or pay them livable wages. And workers still are struggling. They're struggling. They want to do the work, but they don't have the kind of support that they need. So this past Saturday, I conducted a focus group in Detroit with 7 direct care workers who are going into people's homes in downtown Detroit. Story after story that would just break your heart, make you angry, frighten you. And they know, they were more articulate than I could ever be. They know exactly what this workforce needs. They know what the challenges are. They have ideas on how to fix it. They have a word or two for Governor Snyder, which I won't repeat. But they know exactly what is needed, and they know why it's so important to fix it. They can tell you why it's important to fix it. And they will say, ethics aside, social justice aside, it is foolish to not look at what good business sense this makes. For, as you said, they're the ones that are providing up to 80% of the paid in-home care. They are on the front lines, up close and personal, touching the person, can see what's happening, can see a change in condition 5 days before the nurse sees it. Well, what does that mean? So if we pay them more, yeah, they have more money to put into the economy. But having them there, if they're qualified, if they're well-trained, if they love their job, if they're not going anywhere, it will result in better health care outcomes. It will result in lower health care costs. They are the ones that are going to help those people live a higher quality of life, have better health, have lower 30-day rehospitalizations, have lower decubitus ulcers, rates of decubitus ulcers, have less falls, all of these really high-cost adverse events. They're the ones. So it's a real head shaker to me that we don't pay more attention to them. So I'm grateful for champions like Dr. Stone and lectures like this and people like you. And before I close, I just want to tell you one thing. You mentioned, I think your name is Jamie, whoever introduced me. Yes, mentioned a project I have that I'm really quite excited about. I think because I've been agitating for these kinds of changes for 20 years in the state with little traction, and I think we're just starting to get a little bit of traction right now. And I did just get a nice size grant from the Michigan Health Endowment Fund called Impart, and there are handouts in the back if you want to grab one on the way out, because we're looking for people to get involved. And it's the start of building an infrastructure in Michigan to develop and support the direct care workforce. And we have 5 aims, and the first aim is, it's extraordinary to me that they chose to fund this. But what we want to do is build a coalition, starting with an advisory group that has representatives from all of the different stakeholder groups who are going to, from the ground up, because it is hard to get the attention of the politicians. So we're going to go with the community and start from the ground up and bring people together who have never sat in a room together and say, okay, you're an employer, you need employees, you know, you want a quality workforce, right? Okay, you're an employee, you want a good job, a decent job, you want to be trained and paid well. You're a AAA, you're an advocacy group, you're a home care agency. Now, we're all going to play nice, and we're going to talk to each other, we're going to get to know each other, and we're going to figure out how to fix this, okay? That's the plan. That's my big plan. That's what they gave me a lot of money for. So is to get these people together and say, come on, you know, let's put our brains together. Let's have a big think tank and figure out some win-win solutions that we can pilot test, that we can, you know, do the research on. The other aims are also infrastructural, to build a good data platform that Michigan can use to build a great Train the Trainer program. And all of this is built on a previous project I had called Building Training, Building Quality, which Dr. Stone is very familiar with. And we developed here a comprehensive training program for personal care aides and had a robust evaluation component. And it was wildly successful. Employers loved it. Students loved it. Problem is, we can't figure out how to get it into the real world because people say they can't afford it. So now the challenge is how do we get this out there and disseminate it and find creative business models to fund it. So I'm very excited about that program. I'm hoping really this is the nucleus of a statewide coalition that all of you can be part of. So in the back I have handouts on personal care workers in the country and some information on this new IMPART program. So I invite you to take those. I'm happy to talk about B2BQ, IMPART, personal care workers, anything aging at any time. So I hope we can be in communication in the future. Thank you.
Well, thank you for inviting me as well, and thank you for Dr. Stone. That was a really great lecture. I think that really gave a wonderful overview of where we need to go with taking care of all of these older adults who are kind of taking over a little bit. Right. And it's true, you know, I've never wanted to do anything other than be a part of agencies services. You know, I also spent lots of time with my grandparents, and so for me it's just always been home, and so I never thought about the fact that that is a little bit odd and that most people do tend to fall into this work accidentally. And so I've always been in agent services. One of my first jobs was also as a direct care worker. I worked as a nursing assistant in Oshkosh, Wisconsin, where I grew up in Milwaukee, Wisconsin. And it's very different. I think you have a very different perspective when you come up from the ranks of working as a direct care worker and through the system, you know, as a manager and a director of nursing and in leadership and education roles, to be able to understand some of the different dynamics that affect why individuals stay within the field and why they choose to leave. And one of the things we really have to start thinking about that Dr. Stone talked about was these family caregivers, because that's the model that many individuals have used, where your daughter or your spouse takes care of you, but as this generation is aging, those folks aren't so readily available. And we're cognizant of the fact that we're not going to have as many family caregivers available. And so the alternative is we have to have more direct care workers, these nursing assistants that are prepared and ready and able to be able to care for our elders and our family members. And a big part of this is retention. So we can work on recruitment, but we have to keep the people that are already there. And part of this is really thinking about how do we advance supervision. One of the things that takes place in the ways that we interact with elders or that nursing assistants and these direct care workers most frequently interact with elders tend to be in long-term care, home care, assisted living types of environments. And in these environments, when you look at the nurses that are within these environments, these are not advanced practice nurses. These are diploma level nurses and associate degree prepared nurses who are trained at a technical level. So they're trained to perform the tasks of nursing. They're not trained in areas like organizational management, understanding systems, understanding populations, even to some extent fully understanding disease trajectory and how that all works together with communities. And that's a really key thing that's missing. And so what that means is that you have to contrast that into the social workers who are a part of these fields, who at a minimum are prepared at the baccalaureate level. And at what you see most often is that they're prepared at the master's level. So we're kind of not comparing the same two levels of education here when we're talking about the ability to lead within this area. And so one of the things that we really have to think about when you're thinking about it from a social work perspective is how are social workers preparing themselves in leadership positions, which Dr. Stone talked about, but not only just in leadership positions, but how are they preparing others for leadership, because that's a skill set that's not developed readily in nursing at these diploma and associate degree levels, and that's so critical to this area. And so social workers are really in a good position to not only serve as managers, but also to support staff in developing managerial training for the staff. So even if they're not, maybe the director of nursing, they're really going to be important for the administrator of these programs and these facilities to be a key part of developing this leadership training and training in interpersonal communication and leadership, understanding how to manage families and even dealing with balancing work and personal space, right? When we think about the retention of the nursing assistants, some of the reasons that Dr. Stone mentioned, as well as what Dr. Lutz talked about, are areas that keep people from wanting to remain in the area, are areas like training and orientation, the low compensation, and of course cultural competence. And so, and a big part of that is a dissatisfaction with organizational policies and procedures. They get caught up in a lot of paperwork, and sometimes it may feel like nitpicking, when they're the ones that feel as though they're spending the most time with these individuals. They understand their idiosyncrasies, their likes and dislikes, and because they do spend so much time with them, they pick up right away when there's a difference. They might not understand what that difference is or what the meaning of that difference is clinically, like the nurse may be able to, but they know that something's not quite right, and they're the ones that are able to point that out. So what that means for facilities and for leaders is that we have to think about training beyond just the tasks. Training that focuses on what are the anticipated behaviors that we can anticipate for the populations of individuals that we're caring for. If we're looking at it from a clinical perspective, it means training them more so on disease trajectories for the areas that they're in, so they better understand what to anticipate, what's normal and maybe what's not so normal. Looking at specifically dementia care and understanding differences in personality and behaviors so that they understand what, again, is to be expected or anticipated, and some of the behaviors that maybe we shouldn't be anticipating or expecting. Thinking about issues surrounding end-of-life care. How do we know when somebody's dying? That's still a very, very taboo subject in our culture. We don't like to talk about dying because we know that we're going to die, but we just, we'll deal with that later. And so there's never this conversation about, how do we realistically know when someone's closer to that end rather than further away from it, and then how do we adjust care related to that? We also don't talk much about mental illness. That also is very taboo. When you have someone with a mental illness or a mental health diagnosis, they don't get the same type of support, social support, as someone who has a medical diagnosis. Think about someone who's hospitalized with a heart attack. You get flowers and balloons and cards and phone calls, versus if you go to the mental health hospital, it's whispered. We don't even talk about it out loud. So how do we then train our staff, and particularly our direct care staff, to be better equipped to deal with mental health within our facilities and care and the problems that may come with that? And then, of course, you have some of the basic skills that, they may need, like assistance with eating and training on dressing and how to work in teams and how to prioritize tasks. With low compensation, we know that leads to really low job commitment. And sometimes there's not necessarily enough money to raise things, but we can still create an environment in which people are still wanting to be a part of that system. And so that means things like teaching effective listening, encouraging our nursing assistants and the direct care workers to be active participants in care. It also means being respectful and helpful as a manager. Not just giving directions and orders, but what are you doing to be engaged to show that, particular types of work isn't beneath you? And that's a big part of it, as well as something that I think a lot of times managers take for granted is scheduling. More often than not, the higher your level of education and the more your pay is, the more flexibility you have in your schedule. You don't have to worry about things like necessarily punching a clock and having to be there at a particular time and then being penalized if you're not there at that exact time. And we take for granted that it's so difficult to do things like schedule a doctor's appointment and then not having the health insurance to fully cover that doctor's appointment, or dealing with children or aging parents and then not having time off, and some of the things that many of us take for granted that we have available to us that really can create a negative space that also can lead to low job satisfaction and a decreased likelihood that individuals are going to remain in this work. And I think the final area that's really important that we have to take a look at is cultural competence within our systems and how we're within the direct care workers. About half of all direct care workers come from minority backgrounds. And as Dr. Stone mentioned, we're seeing increasing numbers, and we're going to see increasing numbers of diverse elders. And so one of the key components of dealing with this diversity is really beginning to think about what cultural humility means. And really, essentially, what that term means is it means being other-oriented. It's being willing to suspend what you think you know about individuals who are different from you and being willing to and accepting of what those individuals want you to know about them. It means asking questions, being okay with having mistakes, and recognizing a key part of that, what your own values and biases are, because every single one of us have them. But we have to recognize the things that are most important to us, and then how those things that are most important to us affect the manner in which we prioritize things, the manner in which we interrelate and interact with other individuals, and how that may affect our management style, as well as just who we get along with and who we don't. And there's not like a right or wrong way to that. It's just simply an openness about it that a lot of times individuals are so fearful of, or feel like you have to memorize a book of information about different cultural groups, and then you get tripped up because what you read about isn't quite correct with this person, right? And so we're creating a space where it just allows for what we're really getting at, that person-centered care. And the managerial approach to that is then dealing with overtly discriminatory comments that come about. You would be surprised at the number of direct care workers, who have been told, or family members that will tell agencies, I don't want a person of color coming to my house. And then what is the agency response? Some agencies will accommodate that response, and then they can't accommodate it, because if half of your workforce are minorities, what are you supposed to do? And you've told this family now not to worry about it. Or so thinking about what are our responses to not only these types of comments, but the attitudes and actions from staff, residents, patients, and families, and how are we fostering an environment of tolerance, and then developing this managerial response that this is the standard within our organizations. So I'm going to pass it over to Jamie.
Hey. Along with the rest of you ladies, I also want to thank the University of Michigan and Dr. Robin Stone for the opportunity to speak on this topic. It really is quite an honor to be an active part of the community that is Ann Arbor. It is one of the best areas for older adult services and resources. Over the years, I really have come to know so many of you who are really committed and compassionate caregivers that I've been able to learn from and grow in my career. It's exciting for me as I round out the first decade of my career to be where I am today and really have the ability to talk about a population that I love. Working with older adults, especially those living with memory care, and I say living because they are living. They're not suffering, they're living. It's something that I've always felt at ease around older adults as well, as everyone has intimated. My mom was a single parent, and so I spent a lot of time with my busha and my judge, and spent a lot of time in church kitchens making food for funerals, for baby showers, for weddings, and I grew so comfortable around older adults, and I picked up a little bit of Polish, so thank you for the immigration. As I grew older and started going to school, I did my first placement at Glacier Hills. Excited. I knew that I wanted to work with older adults at that point. But talking about kind of falling into accidental care in skilled nursing facilities, I didn't anticipate that I would work in a nursing home or a continuing care facility or assisted living. I really wanted to work in the community. I wanted to work, out in the field. But I kind of fell into it, and I found that there was a really large opportunity for me to help others become independent within a setting. And I think that it's really important to be a part of a system that allows people who traditionally don't have self-determination and independence gain that back as they lose things through the inevitable process of aging. There are so many different people that I have learned to work with, as Dr. Stone said in the presentation. It's not just aides or social workers or the business office, but it's housekeepers, it's facility services, it's everybody who has an opportunity to touch a life. When you work someplace, everybody should have a hand in caregiving. But I do want to talk mostly about the aide population. Those direct care workers really are the backbone of our communities. We all hear about the wave of older adults and the baby boomers, which, by the way, just sounds so much fun. Like, the wave of older adults. It sounds really great. We know they're coming, so I'm very excited about it. Which means that we are going to have a growth in this field. The U.S. Bureau of Labor Statistics anticipates that we're going to see about a 17 to 20% growth in this field by the year 2020. And about currently, 37% of the SENA population right now works in skilled nursing facilities, which is a really large percentage. So I think that, we have a really unique responsibility to look at our workforce and be able to help, shape, recognize, and enhance their skills so that as hopefully direct caregivers start to get more recognition, we will already be a little bit ahead of the curve. So talking about the importance of the direct care worker or the nurse's aide really is often taken for granted. Facilities depend on very specific things in order to maintain their status. I mean, how many of you in here have heard of the Medicare 5-star system? Everybody looks to see what star your facility is. It's a big deal. And really the work that the direct care workers do is a direct result on those measurable outcomes. Talking about skin integrity. I mean, these are very big nursing things. Decrease in aspiration pneumonia, decrease in dehydration and urinary tract infections, decrease in therapies that reduce contractures, decreasing incontinence. All of these things are a direct result of what our caregivers are able to do for our older adults. And what does that equate to? It really equates to money that potentially can be saved if you have a really strong workforce that has the ability to help in that prevention. I can't say it enough, the change in condition 5 days prior. I've been able to be privileged to work alongside a lot of my staff in the assisted living and help with personal care, help with taking somebody to the restroom, help with transfers. There's an intimacy there that is so undeniable when you're caring for someone in such a personal way. It's absolutely amazing. So it just seems to me to be very common sense that if we invest in this workforce, the measurable outcomes that we're going to see from the care that they're able to provide, it is going to be amazing. But enough about the traditional kind of those nursing and things that we can do. The thing that's the most important from my perspective is enriching a life. Think about what these people do every day. They're the hands on your loved one. They're touching your loved one every day. They're doing very personal things for them. They're upholding their quality of life. I heard somebody say once, and I don't even remember, it was in a meeting somewhere, what do you want for your facility? What do you want for your residents? And this came from one of my fellow nurses, who I love, amazing, but she said, I want my residents to be clean and dry. And I thought to myself, if that's what my existence is going to be at the end of my life, is to be clean and dry, there's I mean, I want to be clean and dry, don't get me wrong. That would be preferable. But when I think about self-determination and the lifespan and who I am as a person and what I've done with my life, there's so much more to me than just being clean and dry. I want someone who knows that my moisturizing routine at the end of the day is going to make my life worth living. Okay? I don't want the generic lotion. I want you to contact my family and tell them to go get a free sample of Chanel and bring it into my room, because I'm more likely to use it. You know, I'm more likely to participate. I'm more likely to come alive. And that is the opportunity that we have to build a workforce that is in that room with that person every single day. So knowing all this, I always ask myself, why do we place so low a premium on our direct care staff? Why do we cheapen the labor that they do? You know, we have such an opportunity to do so much better there. You know, also talking about social workers becoming managers, I've been very privileged in my career to be able to make it to a level of an administrator and a director where I'm able to guide direct care staff. Now, it's not easy. There are plenty of challenges, and it's a slow game. You know, you have to make inroads. Caregiving professional, it's deeply rooted in nursing. It's deeply rooted in the clean and dry mindset. You know, we have to redefine what care means. We have to challenge safety versus quality of life, which sometimes can be hard to do in regulated facilities. But I think we have to remain committed that it's something that we have to continue to be aware of and work for. I think also social workers have an innate ability to be able to advocate for people. And I think that's one of the things that we need to do for our caregivers, is we need to advocate for them on behalf of what we know is going to be best for our residents and our families, because families come along, they come along. They're, you know, the residents are 50% of our population, their families are the rest, which makes sense, because again, when we talk about enriching their life and treating the person as a whole, everything comes along with them. You know, we want to also understand that the typical caregiver does have, they have a life and they have a history, and quite honestly, they come from challenges of their own in their personal lives, and we have to help them rise above that to be the best caregivers that they can be. You know, we want to create buy-in, and it's really hard to create buy-in when you're not, when you're treating somebody like they are the dime a dozen worker. You know, I can find a Cena anywhere. It should be, I want to find that person. I want to find that person who is going to give Jamie her Chanel. Oh my gosh. So, you know, I think that we are at a starting point for something great. I think we just have to remain committed and dedicated and continue to talk about it amongst ourselves and, you know, keep moving forward. The one other thing that I think we have to realize is, you know, the value we place on older adults is low. I think that not enough emphasis is placed on this field, because what are we getting from older adults? But we have to remember that we're only here walking on this sidewalk because they laid it before us. And so, you know, we just have to reframe what's going to motivate lawmakers, what's going to motivate policymakers. Unfortunately, it's probably going to be dollars. So let's be prepared to present our numbers and do the quality work, get those outcomes, and hopefully that will carry us into the next generation of having really quality caregivers. And I'm going to get my Chanel.
I want to thank our wonderful panelists and now open it up for questions. We have someone in the audience, I think, who has a microphone. So we have some folks up here on the front row, and I'm going to try not to point. And so if we could keep our questions and comments brief, we can get as many in as possible. Thank you.
Okay, good afternoon, and thank you all so much for the work that you do. As the daughter of my mother, who spent her life working as a nurse's aide in nursing homes, very familiar with the challenges that she went through and being underpaid most of her career for the work that she did. But my question is actually about folks that are at home. And the gap that I find, I work in dementia care, I work for the Alzheimer's Association, and Dr. Stone, you had mentioned that most folks will be cared for in the future in home settings, and that we have to have community-based settings that we can get to. So also working and doing some policy work, CMS came down with a ruling fairly recently that physicians, physicians' assistants, and clinical nurse practitioners could now get reimbursement for care consultation with the diagnosis of dementia or Alzheimer's, some type of dementia, which struck me as really interesting because those, in my mind, aren't typically the folks who are sitting down doing the care consultations. This wasn't social workers. This wasn't frontline nurses. So my question for Dr. Stone or anyone on the panel is, how do we close that gap between sort of the medical model where you get a diagnosis, Alzheimer's or diabetes, and see it in 6 months? How do we make that education happen? And how do we get our older adults to these services and to the workers that they desperately need? What are your thoughts behind that?
I think that's a great question. Quite honestly, again, I think it's great to have a physician or nurse practitioner consult, but for the most part, these are not the folks that really understand what's really going on in the full environment. And I think that, because the medical model has so dominated this that they are the ones that get reimbursed. What I would have liked to have seen is a more team approach that really involves some of the other folks who really understand it, like the social workers and perhaps some of the frontline nurses, and even, God forbid, the direct care workers, who are probably, if they are getting any kind of frontline services, those are the folks who know these people better than anybody else. Having said that, I think it is great that CMS is at least acknowledging that Alzheimer's and related dementias is a constellation of problems that needs consultation that will be reimbursed. And the other thing is that if you've got a really good geriatrician, you are likely to have somebody that has an interdisciplinary team working with her or him. The problem is that most of this consultation is not necessarily going to come from that, because we have a very limited amount of folks who are either licensed as geriatricians or trained geriatrically. So, that's a much larger conversation, is that if you're going to have consultation that's paid for, you want to make sure that you've got consultation with people who know what the heck they're talking about. So I think I applaud CMS for moving in that direction. I think, at the end of the day, what I would like to see much more is really an interdisciplinary approach where there would be a team that actually would get paid. And then figuring out how those dollars flow is going to be a whole other question. But the input really needs to come from the folks who really understand the needs of this population, and it's not necessarily the doctor or even the nurse practitioner. So I don't know if anybody else has any comments on that, but
I'd like to add a little bit. It's a great question. The fact that I guess on the plus side, the good news is that CMS is starting to pay attention, right?
I said the good news is that CMS is just beginning to pay attention to this, and they're making changes like that, and they're doing the same with having conversations about death and dying, end-of-life care, right? The bad news is that they're just beginning to pay attention to this. We have known that the population is aging for the last 50 years. Our head is still in the sand. Their heads are still in the sand. The fact that came down, politicians, decision makers decided it would be the doctors and the nurses doing that, even though it's the social workers who should be doing it, right? Or the care managers should be doing it. I mean, it tells you how far we have to go, how much work there is to do. And I do want to say something, especially to the students in the room. I am so glad I chose a career in social work and did that for 20 years. It was the best decision I ever made. I loved being a social worker with older adults in long-term care settings. And it prepared me so well to go to the next phase of my life, which was to try to do some policy-relevant work, change policy, and start a movement and create culture change. And that's what's needed. And it's kind of shocking that we're at such a beginning stage of this, but it is. This is all brand new. And we need social workers and people who have people skills and can communicate and who can get advocacy skills, who can get out there and advocate and mobilize people and build coalitions and tell politicians and move this thing forward. So I don't know what else to tell you. I wish I had an answer to that, but we're just getting started, and we need help really informing politicians about what it means, what this sector is all about, and what we can do.
Thank you. I had a question. I saw a TV. Oh, I'm sorry. I saw a TV program about a month ago in which the state of Florida, it was on PBS, the state of Florida has a waiting list for, there's a lot of senior citizens that live in Florida, but they have a waiting list for people who cannot afford nursing home care. Maybe their funds have run out. And the waiting list is a long one. They were talking to people who say, they think it's going to be next week or something. It's not going to be next week. I've never heard of that before. I've lived in Michigan all my life. Are any of you aware of states that put people on waiting lists? And I'm wondering, because they can't afford, they need nursing care because they're whatever the reason is. But they are on waiting lists. Now, they didn't say what they do with them. I mean, do they put them in homeless facilities? What do they do with them? That was never discussed.
Right. So what happens is facilities for the most part are for profit, right? And so facilities will have so many beds within the organizations that are dedicated for Medicaid beds or for low-income individuals. So that doesn't mean that the facility is full. It means that they're willing to support this or accept so many dollars of Medicaid beds. So what happens to access Medicare dollars or dollars that come from a different reimbursement system which pays more, that happens after a 3-day hospital stay. So if you go to the hospital and you're there for 3 days, then they'll find a bed for you because now there's some funding, for you. So they put them in the hospital for some time, and then they filter them to the appropriate facility.
Unless they're under observation.
Unless they're there for observation. So you have to watch that because, and that's less than 3 days. And it has to be for skilled care. So typically, if you're in the hospital and you need to be there for that length of time, typically you'll qualify for a stay. What often happens is you'll have individuals in a community setting, like someone with dementia that is maybe declining or becoming too difficult to manage their care, and they don't have a lot of money. And those are the folks that can kind of end up in limbo and trying to figure out what to do. And the solution that ends up happening is they end up in the hospital to figure out where to place them. And then if they end up with, doing tests or finding out that something else is going on, they will eventually end up in placement. But no, there's not like holding cells somewhere where, yeah, we're not stashing our old folks.
Okay, thank you. Are there any other states like Florida, or is it just Florida that you said?
It's not just Florida. That's here in Michigan too. Yeah, that's national.
Okay, thank you.
I don't know about a waiting list for the state, but that's really facility based. So it may just be in Florida they have a higher percentage of facilities that aren't taking as many Medicaid beds.
Hello? Oh, hey. That's where I think we really can also utilize everything we've been talking about in the home health care, because very much like you said, when people are in that crisis mode, then that's when you see a lot of high caregiver burnout, because people are burning the candle at both ends, trying to make ends meet, trying to piece together whatever they can until, you know, some crisis moment happens, and then you have to figure it out.
Thank you.
Hi. I just want to thank everybody for all the panel and everyone what they're doing. I'd like to add a little twist. I'm an assisted living provider, and I spend pretty much all my days thinking about these issues. We have 180 different care staff that we deal with in 3 different communities around the state, from Vibrant Life communities. A little different twist of what some of you are saying. Some of the problems that we find is the institutional nature of the care settings. So again, the nursing homes, I really feel, are pretty much a failed model. And the fact that then the care staff is trying to fit into a poor model is one of the problems. I think, we're into assisted living and we're into a residential model, and when one of the reasons it's so difficult is because you're an assisted living, you're trying to create a home for people, a real home, not an institutional home, a residential home, and yet then we're asking our caregivers to be professional caregivers in a home, where really it's almost, they need to be sort of para-social workers. And so someone said that a little earlier, but I feel like we call our caregivers care friends. And it's a softer name. And their job in our communities is to have a relationship with the residents, so to increase the quality of life. And I guess just part of the discussion, and could talk for hours about it, but is the fact that the settings themselves need to be much less institutional, and then the caregivers or the care friends also, it needs to be a different model of just a hospital or a nursing home caregiver. The caregivers have to be more holistic in their approach. And I think that's part of the problem with even retention and things like that. One other thing I just want to mention on a real common sense basic level. I know when people get paid $9 and $10 an hour, there's attrition. I've been in communities where we've paid $12, $13, and $14 an hour, and everybody stays. So, in all this we're talking about, maybe 50% of the whole problem is just money. And if you paid people $12 to $14 an hour, they'd stay. So I just wanted to mention that.
May I comment? First of all, I commend you for trying to establish a home-like environment. That's really huge. It cracks me up how things just come full circle. There's this new movement. I hear it about 50 times a day because I work in family practice. For person-centered care, person-centered care, person-centered thinking. And I'm thinking, we social workers have had person-centered thinking for 100, 200 years, right? So this is not new. The whole idea is let's get to know the resident or the patient or the client. Can we just have a relationship and get to know each other? And then instead of having a medical model, we'll actually know that you like Chanel lotion and what you value, and and then honor those choices, right? Person-centered thinking, that's what we're going to call it now. But that's where I totally agree, and training programs have to instill that. And that actually is the big difference between the CNA training program, which is a medical model, and something like what we've created here with this better building, training, building quality. There are 4 modules alone on person-centered thinking, person-centered concepts. How do you translate that into the care that you're providing? So that's huge. I totally agree with that. Pay, absolutely. This focus group that I led in Detroit this last weekend, they said, pay us more. Pay us more. And I said, okay, how much? How much do you want? And they said, well, the nurses get like 20. They come in, they spend 5 minutes, they leave, they get $25, you know? How about paying us $25? And I said, well, I'm not sure that's actually going to happen, you know, and part of it is the degree, the education, that the nurses have a degree, and they said they get that, they get that. And we went around in circles. Turned out somewhere between $12 and $15 would be enough. They all agreed. They said 19 would be great. They wouldn't go lower than 12, and then they compromised and said 15 would actually make a huge difference. So the question is, who's going to pay for it? And that's where we need lobby, you know, people to advocate and lobby and push the politicians and push for. I mean, some of these workers have been doing this for 30 years and they're still getting $7 an hour. It's just not right. So, and then we complain about turnover.
So that actually is my question. As we're talking about people having less money, wanting the people to care for them get paid more, and more people needing services with fewer dollars, where are we looking for this money to come from? Are we looking wholly through Medicare, Medicaid, which are not really equipped right now to do that at all, or are there other avenues that people are considering? Can someone talk about that?
I know that traditionally there's a thought process or a model, the three-legged stool that people think about when they pay for their care. There's generally pensions, which are kind of becoming non-existent these days, Medicare, and then whatever savings are coming up, and then some people, you know, have invested in long-term care insurance. I think the thing that really is very scary these days is there really is no money for a lot of people to pay for this type of care. When you think about, you know, the average cost of a nursing home is $8,000 to $12,000 a month. Not many people can afford that, especially with disappearing pensions, you know, Social Security being in question, Medicare, Medicaid being in question. I think that's why people are frankly so terrified of what's going on in the world right now, because it only further threatens what are we going to do with the wave of people that we know are coming. So I think people are right to be a little scared, which is why we all have to, I think, find our voice to advocate for it, because it's terrifying.
Yeah, I mean, I think it depends on the audience of who you're talking about. For example, I think there's a lot that leading age members, as talking about from my leading age hat, I have said this to our own members, that we have a lot of, there is wiggle room in a lot of our budgets that we don't really know very well because we don't look at it. We have dollars that are being spent on training that are being, what I say, is thrown down a rat's hole. We have potential for redistribution of dollars in how we reimburse all of our staff. Top staff get a whole heck of a lot more money and a whole lot more benefit. I've heard this from board members, and I'm on a board of 2 of our members in leading age, and I think some of this has to be a redistribution of our own dollars within our organizations, because we're talking about $2 and $3 increases for frontline. That is a decision that is made, and it's much easier, to be honest with you, to do this in a nonprofit than it is in a for-profit, but I've said this to some of my for-profit friends too, because I happen to be on the quality board of HCR Manor Care, so I'm not afraid to say that as well. There is money that can be redistributed in terms of how we think about paying professionals. To speak to the Care Friends guy, who I think is, you raised some really wonderful issues around institution versus community-based, and I think we should all think about all of our settings as community-based, no matter where they are. But the truth of the matter is, the more you focus on a holistic approach, the more competencies you need, not less, which means these are more professional jobs than they are when they are just very task-oriented, which means that they should be paid even more. A care friend who is doing the kind of work that you're talking about is a professional that is combining significant social work skills and healthcare skills. And yet we dumb these jobs down. So I think from a provider perspective, we need to take a look at our own budgets. From a societal perspective, we actually could be paying for more if we paid more taxes. There's nothing that says we pay enough right now. Why do we have Medicare and Medicaid reimbursement rates that are so low? And in Michigan, you're not in really bad shape. Try living in Illinois for a while. But, you know, these dollars support our labor. And that is all it supports. If you look at our budgets, our budgets are about 80% labor, particularly in aging services. So as a society, we are accepting what we pay. I mean, I want to be perfectly honest with everybody. We accept it as a society. And, you know, it is a question of what it is we're willing to pay for. You know, there have been efforts to try to get some type of long-term care, more social insurance-oriented long-term care, that if we were able to get that passed across the entire population, distributed it across the population, everybody would have a little bit more money to pay for the care that is being provided. In Germany, all of the staff get paid a heck of a lot more, and they all pay into a social insurance fund, and they get money, they have money to pay for their workforce. So, you know, I do think that it is a societal question, and I also think that from an employer perspective, we as employers have a responsibility, but the society has a responsibility to say, you know, what are we willing to pay for? And, you know, it starts with us in the private sector, but we also have to push on the public sector because we are heavily dependent on Medicare and Medicaid dollars. And we accept those reimbursement rates. And the only way those dollars are going to go up is if we pay more. Medicaid and Medicare are not magic programs. They're paid for by us as taxpayers. We support those programs in order for them to be there. And that's the beauty of social programs, because the dollars are redistributed and they're distributed across generations. So, I mean, it's a societal question for us, and, you know.
I've testified a number of times in Lansing, and what response was, why are we putting so many resources in dying flowers when we can use it in other places, like child welfare services? So that's an area that you four have to address. And policy issues and economic issues. So we have to do some changing there. Now, assisted living, you know, that's a marketing term, right? And my problem with my friend over here is we get calls all the time. Well, we have some folks who ran out of money, so they're going to have to leave assisted living. Where can we go? Now, fortunately, we have supported housing, permanent supportive housing, that occasionally we can take one in, and we essentially charge 30% of their income. That's the rent they pay. So is there a plan for the assisted living folks to do something for folks who are running out of resources and can't afford assisted living anymore? I'd really like to know, and if we can work something out, that would be very helpful.
This may be a question that we can talk about while we mingle over refreshments. It sounds like something maybe far more involved than we might be able to cover in just a few moments. But I'll give our panelists just a moment if they do have some thoughts on that before we wrap up.
We'll see you at the break.
Wonderful. Wonderful. So before we conclude, and we thank you all again for attending, we thank our wonderful speaker, Dr. Stone, and our panelists. We do have just a small token of our appreciation for them, which I'll give them in just a moment. And then, again, we invite you all to stay. We have lovely refreshments here, and we can continue the conversation over those.